What up, crew? I hope everybody is having a great break and is super enthusiastic about getting to watch this video. This is in advance of your lower extremity lab, partially so that way we can use some of that afternoon to review for your practical and make sure that you have those skills confirmed and that you feel confident with them for your practical. So this is coming from your mall textbook, I believe. Yeah, your mall textbook. You can look through the learning objectives. I've added a couple things to this PowerPoint, but I will upload. Self-assessment activities. So review the movements of the hip, knee, and ankle. I gave you guys a handout of those with normal range of motions. I also included the spine on there. Make a list of which movements and how much motion you need to sit down, stand up, climb into a bathtub, don your socks, and get a splinter out of your heel. I did that for you with your other handout. And try to do these actions without movement at your hip, knee, and or ankle. And that's just to let you understand where a patient's coming from. Back surgery and braces. So sometimes after back surgery, someone will need to wear a back brace. You guys have seen the TLSO in class. You can go ahead and watch that video if you would like. I included a couple images of two TLSOs here at the bottom left on your screen. The hard turtle shell like you guys saw in class. And then there are also some softer TLSOs that's pictured in that second image. And then there are LSOs as well that don't come all the way up through the thoracic spine. It's just a lumbar sacral orthosis. But those can also come in the hard turtle shell or the softer brace that's pictured on the far right there. So why might a client need this brace? We're going to look at things like status post-surgery, immobilization following a trauma, typically with a fracture that they want to heal without surgical intervention. Postural correction. My niece had to wear a TLSO to sleep in at night when they were correcting her scoliotic curve. So that is a potential reason that you'll see some of these back braces. How are they going to affect doing ADLs and IADLs? And so we need to think about the limits that are being placed on the thoracic and or lumbar mobility that are going to affect ADLs that require things like bending and rotation and anything where we need the spine to move. And so consider the implications for your patients. Getting in and out of bed is a difficult one, and that's something that we'll talk about. Real quick, let's run through the anatomy of the spine. So we talked the other day in class how each levels of our vertebra are shaped a little bit different based on the motion that they have and the demands that they have, but the essential fact is that as we get closer to the bottom where we have more body weight, we need a bigger vertebral body to support that. The role of the vertebral column is to support the body, support the spine, or support upright posture through the thorax, but also to protect the spinal cord. Our vertebral column is made up of 7 thoracic or cervical vertebrae, 12 thoracic, 1 for each rib, 5 lumbar, 5 sacral, and 5 coccyx. But our 5 sacral vertebrae are fused into our 1 sacrum, and our 5 coccyx vertebrae are fused into our singular coccyx in the body. And remember, we only have 1 coccygeal nerve. The canal is where the spinal cord runs through, so that's the main part, in the main foramen in the center. And then the foramina are where the spinal nerves exit, and so those are going to be the foramina on the lateral aspect of the vertebral column. So why do we care about the spine? The reason is that because patients experience back pain, and that's something that we're going to help them cope with. 70 to 80% of people experience back pain at some point in their life, whether it's trauma related or they just have poor posture over their lifespan or they have injuries or overuse, whatever the case may be. From a PT standpoint, this typically has some relation to a weak transverse abdominis, and so it's really essential for spinal stability to have an activated transverse abdominis. And so we teach patients to draw in their belly button during transitional movements and really focus on activation of that muscle and then strengthening of that muscle. From an OT standpoint, you guys can help support PT goals by helping to encourage carryover in those transitional movements by encouraging patients to draw in their belly button. But you can also help support the patient's goals, knowing that that's going to help to address their pain and then modify activities in their ADLs that are going to exacerbate their pain. So we want to teach them to limit how often they have to maintain a standing position if they experience increased back pain with standing, or vice versa with seated. We want to teach them, again, those transitional movements. How do we take things that need to be done with bending and lifting and move them up to a waist or shoulder height so that we don't have to bend and lift, and teaching them how to modify those activities. So looking at some causes of back pain, we can look at bone spurs, herniated discs or degenerative discs. Those patients are typically going to prefer positions of extension. Arthritis or ankylosing spondylitis is going to cause a lot of stiffness. Fractures typically are going to come with immobility in order to let the fracture heal, and that can have its own deconditioning effects. Facet joint problems are going to affect how each of the vertebral levels are articulating, and that can cause pain and affect mobility. Osteomyelitis, spinal stenosis, these patients are going to prefer a flexed position. Spondylolisthesis, extension is going to be contraindicated in these patients because this is going to be where we start to see an anterior slippage of the vertebra, and extension would exacerbate that anterior slippage. Herniated or ruptured discs, kind of going back to what we said before in disc degeneration. Not really sure why those are on the slide twice. So with pain, we can also see neurological symptoms in the back, and that those can come in the forms of radiculopathy. Radiculopathies can be upper extremities or lower extremities, but it is when we see the patterns of sensory loss and motor loss following a dermatomal and myotomal form. It's radiating from the center or the spine where it's coming from out into the extremities. And so we have this radiating pain in a radicular pattern, meaning it follows either a dermatome or myotome. And then sciatica is one of those things that kind of gets used a lot to explain lower back pain that extends down the leg. But what it's really talking about is involvement of the sciatic nerve. And so that can come from a couple of different places, one being the lower back, another being the piriformis. But when we see a radiculopathy in the lower extremities, we tend to refer to it as sciatica just because that's the most commonly experienced. Classifications of back pain can be acute, so it's just happened. Subacute, we're trying to recover from it. It hasn't reached a chronic stage yet, but we're not still in the acute inflammatory, can't move it a whole lot stage. Or chronic, it's something that's persisted for a long time and they've had to deal with it for a while. Surgical interventions for the spine can include a spinal fusion where they will go in and fuse levels of the vertebra to increase stability. A laminectomy is where they will remove the lamina of a vertebra to increase space and decrease pressure, typically on the spinal nerve roots that are exiting through the foramen where they're being compressed. A foraminotomy is where they have removal of the foramen. A discectomy is where they will remove the disc. Typically, that's because of degeneration, and discectomies commonly occur with a spinal fusion. Artificial disc replacements are where they will go in and put a fake disc in to replace a degenerated disc. Interlaminar implants are where they will help to increase stability of the lamina, and it's basically like an ORIF for the lamina. And then kyphoplasty is where they go in and inject concrete into the vertebral body to help repair a fracture. The picture on the right here, I think, does a good job representing the different levels of disc degeneration and how you can see that affects the space between the vertebral bodies and therefore the articulation, and why that would cause a patient pain. Some clients fitted with a TLSO will have to wear it for up to 10 to 12 weeks following one of these surgeries, and so it's important to teach them how to accommodate their life with the use of the TLSO. When we treat patients with spinal dysfunction, or especially following spinal surgery, our main focus is going to be education and adaptation. So we want to teach them the things to avoid, the things that they're not allowed to do, and how to modify and adapt their tasks to make them as functional in their day-to-day demands as possible. Back precautions are extremely important to learn. That's going to be your no BLT. So no bending, no lifting, no twisting. And so we don't want patients bending at the spine. We don't want them lifting things greater than 5 pounds. And we don't want them twisting. So no rotation movements. And those are really important because those precautions can be in place 6, 8, sometimes up to 12 weeks, depending on what kind of surgical intervention they've had. And they can cause damage to the surgical repair if they don't comply with those precautions. We also need to teach patients body mechanics because that will fall in line with their ability to maintain those precautions. Shoulders should always move with their hips. They need to not bend at the back. They need to use their legs if they are bending down to lift anything up so that they are not violating the bending precaution. And remember that lifting shouldn't be greater than 5 pounds. For bed mobility, we need to teach them log rolling techniques in order to comply with those spinal precautions. So, we keep the side that we're rolling towards, we want to keep that lower extremity straight. We'll bend the knee of the opposite lower extremity so that we can push. And keep their shoulders moving with their hips so that they can log roll their whole body as a unit to the side before they try to sit up. We'll have to teach them donning and doffing the TLSO. I hope that you guys had time to practice that, but if you did not and you would like to do that in class with me, just let me know when we do the lower extremity lab. Teach patients to sit on higher surfaces with arms so that way they don't have to try to stand from a low surface and put undue strain on the spine. Use things like raised toilet seats and shower chairs and other adaptive equipment that are going to help them modify their tasks in order to comply with their precautions and maintain independence. Moving down the spine, we get to the pelvis, which is three bones that are fused together and makes two innominates, and those two innominates help form our whole bony pelvis. So those three bones are our ilium, our ischium, and our pubis, and they're held together at the posterior by the sacrum, and the anterior held together at the pubic symphysis. The innominate bones contain the acetabulums, where the hip articulates. The most common injury here is going to be probably SI joint dysfunction or sacroiliac joint dysfunction. But traumatic events typically cause fracture, and that's what you will treat more clinically. Treatment for fractures can include traction, use of external fixators, or often bracing just for immobilization to try to allow the pelvis to heal on its own. Intervention in these patients is going to include use of appropriate mobility tools, such as crutches or walkers. The use of which mobility tools and how we teach patients to use them is going to depend on weight-bearing status, and we're going to go over weight-bearing status in a few minutes here. Mobility with these patients is slow. The pelvis is the bony connection of the lower extremities to the trunk, and so when patients have a fracture in this region, they typically require slow movements in order to have the stability that they need to get through whatever functional demands they have, especially depending on weight-bearing precautions. We'll teach these patients to log roll, again, sit on higher surfaces with arms so they're not having to stand from lower surfaces, use raised toilet seats, shower chairs, and other adaptive equipment that helps maintain their functional independence. Articulating with the pelvis is going to be the femur that creates the hip joint. So the acetabulum of the pelvis articulates with the head of the femur to create the hip. This is a ball and socket joint. It is triaxial. We have less motion at the hip than we do the shoulder because we have more stability at the hip than we have at the shoulder. And remember, we talked about the trade-off. The more mobility that we have, the less stability we have. The more stability we have, the less mobility we have. The ligaments of the hip that help create the articular cartilage are what provide that stability. And the way that they wrap around, they kind of create this spiral in their attachment points to help provide that stability to the hip. Part of why that's important is because those ligaments are disrupted for hip replacements, and so hip precautions, which we will go over, become very important to know and make sure your patient is strongly educated on. The hip also has a labrum that helps deepen the socket and provide stability the same way that the shoulder does, and a synovial membrane to provide nutrients to the joint, and is encased in a joint capsule that is partially made up of the ligaments of the hip to, again, reinforce that stability. Common problems we can see in the hip are going to be osteoarthritis, rheumatoid arthritis, avascular necrosis, which is where the blood supply to the head of the femur gets cut off and the bone dies, and can cause fracture and other problems, typically resulting in a hip replacement, fractures, or labral tears or impingements. So those are all common problems that patients with hip pathologies can experience, and or diagnoses that they can experience. And strength and mobility can go a long way with the hips, and so anything that you can do to help support strengthening and promoting appropriate mobility of the hip joints to emphasize patients' functional needs is going to be an important intervention. Also, modifying activities as needed. Surgeries that we will see for patients with hip problems are going to include an ORIF, which is an open reduction internal fixator. And that's where they go in and put a rod in the femur and typically some screws to help secure a fracture site. A THA, or a total hip arthroplasty, is going to be where they go in and replace the head of the femur and insert a rod into the existing shaft of the bone to create a whole joint replacement. There's actually four different approaches, but the superior approach is new enough that it's not in this textbook. But a posterior approach, an anterior approach, and a lateral approach. Your posterior approach and your anterior approach are going to be your two most common, with your posterior approach going to be your overall most common. A hemiarthroplasty is where they only replace half of the joint, and then a revision surgery is where they go in and revise something that's already been surgically repaired. So looking at hip precautions following a total hip replacement, an anterior approach is going to include no hip extension and no hip external rotation. An anterior approach is less prohibitive and doesn't require as much functional modification, but is not as common as a posterior approach. And so familiarizing yourself with both is very important, but posterior approaches are far greater risk of dislocation and are more commonly performed. And so I would be wary on making sure you can determine from your chart what kind of hip replacement your patient has had and what precautions you need to educate them on. For a posterior approach, we want no hip flexion greater than 90 degrees. So that means we need to be careful of how our patients are seated and make sure that they're never seated in a chair that is lower than their knees, because that will automatically put them in hip flexion greater than 90 degrees. We also need to make sure that they have no hip internal rotation, which means when they turn, we have to teach them turning towards the non-operative side. If they turn towards the side that was just operated on, they're going to inadvertently internally rotate as they pivot on that planted lower extremity. And then no hip adduction, so no crossing midline with that hip. That's important for laying in bed most commonly. We have to teach them not to cross their ankles when they lay in bed, and prevent anything with bed mobility that would result in their crossing their legs. We typically need to be careful with ambulation if they have abductor weakness, but bed mobility is the most common area of dislocation for that one. So weight bearing, this is going to fall into our weight bearing precautions and how much weight we are allowed to let patients place on a certain extremity. We're going to primarily talk about lower extremities here because that has the greater functional demand, because most of our lower extremity functional activities happen in a closed chain position, which means they result in weight bearing. Most of our upper extremity activities are open chain, and so we don't have to be as cognizant of weight bearing precautions in the upper extremity, but it's important to know that they exist for the upper extremity as well. So especially for things like transfers, when we teach patients to push up through their arms, if we have a weight bearing precaution in the upper extremity, we can't teach them to do that. So going through these precautions as they apply to lower extremities. Full weight bearing is that the patient is medically cleared to put 100% of their weight on their foot, and the doctor wants you to get them to put 100% of the weight on the foot. We're trying to get them to push as much as we can to encourage weight bearing on that extremity. This is a less common recommendation than weight bearing is tolerated, which is at the bottom of this list. Weight bearing is tolerated means that they are allowed to put 100% of the weight on it, but it's going to be up to what the patient can tolerate based on pain and strength. And so this is more commonly utilized post-op because doctors want you to push the patient to get to 100% and get it at the patient's pace. And so full weight bearing or weight bearing is tolerated. Both mean that you can put 100% of the weight, but one means that the patient can drive the bus a little bit more. Flip that to non-weight bearing. This means absolutely no weight can be put through that extremity. And so this is when we're going to teach patients to hop if we need to. But we cannot put the foot down. It can't be a balance point. It has to be elevated for transfers, elevated for ambulation. There is no weight allowed to go through that extremity. Partial weight bearing is going to be 1 to 50% of the weight, and that's going to depend on the doctor's orders. If it just says partial weight bearing in the chart, clarify, is that 1 to 50%? A person who is partial weight bearing at 50% can stand on both lower extremities at the same time and be compliant with their weight bearing, because 50% of their weight would be on the non-affected leg and 50% would be on the affected leg. But if they are 25% weight bearing, then we would have to teach them to weight shift over to their non-affected leg so that only 25% it was on that affected leg for any given standing task. Foot touch weight, TDWB, I believe is going to be the same as toe touch weight bearing, as far as there's no actual weight put through it, right? So the patient can use it as a balance point. It can be set on the ground, but we cannot let them push any weight through it. The difference between TDWB and TTWB is that the Foot is down and we have heel contact in TDWB. In TTWB, just the toe is down, so the patient is in a position of plantar flexion. This is again going to depend on physician's orders, and you can clarify, but this is just letting the patient use that extremity to balance but not put any weight through. So how do weight-bearing restrictions impact any of our patients' ADLs or IADLs? And the big thing for lower extremities is that most of the ADLs and IADLs are going to have to be performed in a seated position in order to limit weight bearing on that extremity, or train to shift weight towards the affected side depending on how much weight they are allowed, or teaching them to shift weight towards the affected side when we're trying to encourage greater tolerance for weight bearing. And so considering what your goals for the patient are important in establishing how you're going to set up your ADL and IADL performance. Moving on down to the knee joint. So the femur articulates distally with the tibia. It doesn't actually have a bony articulation with the fibula. And then anteriorly, the patella articulates with the femur. The meniscal cartilage sits between the femur and the tibia to help increase bony congruency, because the super round heads of the femoral condyles don't sit well on the really flat tibial plateau. And so the meniscal cartilage helps to improve bony congruency and also serves for shock absorption. Ligaments of the knee that provide static stability are going to include your anterior cruciate ligament, which runs from the posterior femur to the anterior tibia, your posterior cruciate ligament, which runs from the anterior femur to the posterior tibia, and they cross each other, so that's why they're called cruciate ligaments. And then on the either side, you have your medial collateral ligament and your lateral collateral ligament, attaching the femur to the tibia medially and the femur to the fibula laterally. Muscles that provide dynamic stability to the knee are going to include your hamstrings, your quadriceps, and your gastrocnemius. Common problems that you will see in patients with their knee are going to include osteoarthritis, rheumatoid arthritis, and post-traumatic arthritis. So what do they do for these patients? They cut them open and give them a new joint. Knee surgeries are probably one of the most aggressive orthopedic surgeries that exist, and if you get the opportunity to observe a surgery, don't be scared by a knee surgery, but they are like a construction scene. We're going to see those documented as TKRs or TKAs for total knee replacement or total knee arthroplasty. We can also see partial knee replacements where they will only replace one of the femoral condyles, or knee resurfacing where they'll go in and kind of shave off some of the osteophytes or bone spur development. Interventions in patients' status post-knee surgeries are going to need to do everything that keeps the joint moving. Somebody who locks their knee out in any position, whether it's an extended position, a partially flexed position, a fully flexed position, all of those are horrible. And the biggest thing that we need to know for the knee is that it needs to keep moving. So we'll help patients manage ADLs the best we can, but we don't want to modify activities as much because we want to encourage full knee range of motion. We're going to promote functional mobility, and adaptive equipment might be limited by the doctor because of that encouragement of full range of motion. Moving on to aquatic therapy. I think aquatic therapy is great, especially when I did home health in Florida. If a patient had a pool in their backyard and they were medically appropriate, we were in that pool because, especially for orthopedic conditions, it helps to de-weight the patient, takes pressure off the joints, increases the mechanoreceptor response and proprioceptive response, and helps to promote comfort. That being said, it is really important that with this slide coming after all of these orthopedic surgical interventions, that you know aquatic therapy is contraindicated following surgery until the incision site is completely healed. We don't want a patient submerging an open incision site where they can then have a potential source of infection. So unless you are using an occlusive dressing that's going to prevent any water from getting into the surgical site, or the incision site is completely healed, aquatic therapy is contraindicated. Outside of that, the properties of water can be used to increase or decrease the demand on the muscles, to promote muscle strength, muscle tone, weight bearing, joint pain, joint flexibility, balance, healing, and sensory perceptual problems. And those are all kind of the benefits that I started talking with. General orthopedic considerations to keep in mind are going to be post-surgical complications such as DVT. So following surgery, patients are at an increased risk for deep vein thrombosis. And so we need to look out for signs like pain, warmth, inflammation, redness, for DVT. Infection, same thing, especially around the site of the surgery, but also extending in patterns of blood distribution from the surgical site. We want to look for warmth, redness, oozing from the surgical incision, any bad smelling odors from the incision site, all those signs of infection. Safety wise, we want to monitor lab values, especially looking at hemoglobin. A patient with a hemoglobin level less than 7 should probably not be doing therapy. They're most likely going to be on hold. That's going to be one of our levels to contraindicate therapy at that time. And most of the time, if they are in a hospital setting, they're going to get a blood transfusion to address that low hemoglobin level. We also want to pay attention for orthostatic hypotension, and so that's going to be when a patient's blood pressure falls as a result of their change in position from supine to sit, sit to stand, anything that causes them to have an increased demand on the vascular system to maintain blood pressure. We see orthostatic hypotension clinically defined when we have a drop in systolic blood pressure that is greater than 20 millimeters of mercury and a drop in diastolic blood pressure that is greater than 10 millimeters of mercury. These patients need to be careful with initial transitions to stand, being educated on taking a minute to take a few deep breaths, pumping their toes before their ankles before they go to stand, so that way we have some circulation of the blood back to the heart, so that way the body can maintain blood pressure, and not initiating ambulation immediately upon standing until their body has had a time or an opportunity to respond with vasoconstriction. We also need to teach fall prevention techniques to these patients to prevent future different orthopedic conditions. Um, Paying attention to debility and deconditioning. When a patient has orthopedic conditions, they can be self-limiting before they seek intervention, and that can cause decondition and debilitation in their functional life. So we need to be able to address that. Looking at pain considerations, orthopedic pain needs to be trained on how to perceive. So remember we talked about how pain is perceived in the thalamus. And so there are some times where no pain, no gain is an accurate statement as far as we need to teach the body that this doesn't actually hurt. But we also need to listen to pain in orthopedic conditions because the body's trying to tell us, hey, something isn't going right. And so most of the time, especially in re-educating patients on what is a pain-free range, we're going to start things in a range of motion that is shy of pain, trying to gently increase that and promote strength outside of that range of motion so that we can work around the patient's pain. Cognition, we need to just pay attention, especially if they're an operative patient, that they aren't experiencing the effects of anesthesia with temporary or underlying confusion and how that can affect their functional mobility. Psychosocial impact, understanding the implications on a person's overall mood and affect in regards to what being limited and what you would like to be able to do can be like. And occupational performance, what things do they need to get back to? What is it that they can't do because of their orthopedic injury? Quick knowledge check and then you are done. So by the end of this chapter, you should be able to answer the following questions. True or false? It is important not to broach the subject of sexual activity with clients unless they ask. I'm going to go ahead and say that is false, especially in the OT setting. You guys have to be able to talk to patients about anything that they care about, and a patient may be really uncomfortable to bring up sexual activity, but it may still be really important to them. And so you creating the space for them to be educated on that may be helpful. Keep the conversation appropriate, but give the patient opportunity. A client with back injury will never play golf again. Also false. We need to educate them on what precautions they have as a result of their back injury. But remember, a lot of OT is about modification and how can we get a patient to be able to do what they want to do without violating what they can't do. All clients with hip replacements must follow total hip precautions after surgery. This is true. You just need to pay attention to which direction which approach the hip replacement was, and so that way you know which precautions to abide by. Anterior and posterior are going to be your most common. Lateral and superior are the least prohibitive and may be perceived as not having precautions, especially by the patient, but you as the clinician should be informed on what the approach was and double check what are your precautions. Hope you guys have enjoyed. See you after break.